Nurse Kayla Brennan almost sent the man in Bay 7 to the psychiatric overflow unit before a folded, laminated card fell out of his jacket pocket during a routine belongings inventory. A card that would completely upend everything the ER staff had assumed about him in the 2 hours since his arrival. The man, later identified through the discovery in his pocket as Dr. Samuel Whitcomb, had arrived following a fall near a downtown overpass, brought in by paramedics who had noted visible signs of exposure and malnutrition alongside his disorientation, details that had immediately shaped the entire treatment team's framework for understanding his case. Probable psychiatric crisis, possible substance involvement. The attending physician, Dr. Reginald Foss, had noted during initial assessment, his examination brief and somewhat perfunctory given the specific assumptions already forming around the case. Let's get him stabilized and transferred to psychiatric evaluation once we've ruled out anything acute. Kayla, assigned to his ongoing monitoring while the transfer paperwork processed, approached her duties with a specific distracted efficiency, checking his vitals with practiced routine while barely engaging with his continued fragmented mumbling. "The differential's wrong," Whitcomb muttered at one point, his voice weak but carrying a specific, urgent insistence that Kayla, focused on her documentation, only partially registered. "You're missing something. The presentation doesn't match what they're treating." "I understand you're not feeling well," Kayla said, her tone carrying the particular gentle dismissiveness reserved for patients whose statements weren't expected to carry genuine clinical weight. "We're going to get you the help you need." "Listen to me," Whitcomb said, his voice gaining a fragile but distinct clarity now that someone was finally engaging with what he was actually saying. "The patient in Bay 4. I heard the nurses discussing his symptoms. That's not a simple appendicitis presentation. That's early sepsis from a missed perforation. Someone needs to reassess him immediately." Kayla, hearing this specific, detailed clinical assertion from a patient she'd already categorized as experiencing a psychiatric crisis, found herself dismissing the statement almost reflexively, filing it away as further evidence of his disorientation rather than considering it as potentially valid clinical information. "I'll make sure the team is aware," she said, a response designed more to placate than to genuinely act on what he'd said, continuing her routine documentation without further engagement. It was during the standard belongings inventory process, conducted before his anticipated transfer to psychiatric services, that Kayla's understanding of the entire situation shifted with sudden, disorienting force. Going through his jacket pockets as part of routine protocol, she found a folded, laminated card, weathered and worn but still clearly legible, tucked alongside a few other personal items. A medical license. Dr. Samuel Whitcomb, M.D., board-certified in internal medicine. Kayla stared at the card for a long moment, the full weight of what she was looking at slowly settling over her. "Dr. Foss," Kayla called out, her voice carrying a sudden, sharp urgency that immediately drew attention from nearby staff. "I need you to see this." Foss, reviewing the license with visible confusion, turned toward Whitcomb with an entirely different kind of attention than he'd offered during the initial assessment. "This is yours?" Foss asked, holding up the license. "Yes," Whitcomb said, his voice still weak but carrying an unmistakable clarity now that someone was finally engaging with what he was actually saying. "I practiced internal medicine for 18 years before circumstances I'd rather not detail right now led to where you're finding me today. I still remember every year of that training, even now, even like this." "You mentioned Bay 4, Kayla said slowly, the earlier dismissal she'd offered suddenly carrying a very different weight. "You said something about sepsis, about a missed perforation." "I heard the nurses discussing his vitals during shift change. Rising heart rate, low-grade fever, abdominal pain that's not resolving the way a standard appendicitis case should be responding to the current treatment plan. That pattern concerns me. It's not conclusive, but it's worth a second look before you assume the initial diagnosis is definitely correct." Foss, staring between the medical license and the patient who had spent the past 2 hours being treated as a psychiatric case rather than a genuine clinical resource, found himself confronting an uncomfortable, rapidly evolving understanding of the situation. "Get me the chart for Bay 4, he said, his voice carrying a new urgency. "Now." The chart, reviewed with fresh attention given Whitcomb's specific concern, revealed exactly the pattern he had described. Vitals trending in a direction that the treating resident, focused on the straightforward appendicitis diagnosis, hadn't yet fully registered as concerning. Additional imaging, ordered based on Whitcomb's flagged observation, confirmed a perforation that standard imaging protocols for uncomplicated appendicitis hadn't initially been designed to catch. A complication that, left unaddressed for much longer, would very likely have progressed to the kind of severe sepsis that could have proven fatal. The patient in Bay 4 was moved immediately to emergency surgical intervention, addressing the perforation before it could progress further, a complication caught specifically because of the observation offered by a man the entire treatment team had spent hours dismissing as experiencing a psychiatric crisis. Kayla, standing beside Whitcomb's bed as the immediate crisis in Bay 4 resolved, found herself confronting the specific, uncomfortable weight of her own earlier dismissiveness. "I'm sorry," she said quietly. "I didn't take what you said seriously. I assumed, because of how you arrived, because of the initial assessment, that nothing you said was going to be clinically relevant." "I understand why," Whitcomb said, his voice carrying more weariness than bitterness. "I look the way I look right now, and I understand what that communicates to people, even to people trained specifically to look past appearance and treat the person in front of them. It happens more often than you'd think, and I've stopped being surprised by it, even though it still stings every time." "How did you end up here?" Kayla asked, the question carrying genuine curiosity now, rather than the earlier distracted dismissiveness. Whitcomb was quiet for a long moment. "Substance dependency," he said finally, his voice carrying the specific honesty of someone who had made peace, however painfully, with his own history. "It started small during residency, the way it often does, managing stress, managing the specific weight of the work. It progressed considerably beyond that over the years. Cost me my practice, cost me my family, and eventually cost me everything I'd built. I've been living on the street for approximately 14 months now." "But you still remember everything, the clinical knowledge, all of it." "That never left. Everything else did, but the training stayed. I think, in some strange way, it's one of the only things left that still feels genuinely mine." Foss, returning to Whitcomb's bedside once the crisis in Bay 4 had fully stabilized, approached with an expression that combined genuine gratitude and visible discomfort about the preceding hours. "You likely saved that patient's life, a complication we would have caught eventually, but possibly not soon enough given how the standard treatment protocol was proceeding without your observation. I'm glad I could help. Though I understand my ability to offer that help nearly went entirely unheard given the circumstances of my own arrival here. You owe me a considerably more serious apology than I think this conversation can fully address. We assessed you based on appearance and circumstance rather than actually engaging with what you were telling us, and that assumption very nearly cost another patient his life." The hospital's quality assurance team, reviewing the incident given its serious implications for patient safety, initiated a formal examination of how the treatment team had handled both Whitcomb's own care and the delayed response to his flagged clinical concern. "I want to understand exactly why a specific, detailed clinical observation was dismissed for as long as it was," the hospital's chief medical officer said during the review. Foss and Kayla present alongside several other staff members involved in the initial assessment. "We categorized him as a psychiatric case based on his presentation and circumstances," Foss admitted. "That categorization shaped how seriously we engaged with everything he said afterward, including information that turned out to be clinically critical and completely accurate." "He identified himself as a physician," the CMO said, "through the medical license found in his belongings. Did anyone consider that his clinical observations might carry genuine weight independent of his current circumstances?" Not initially, Kayla said, her voice carrying the specific honesty of someone unwilling to deflect from her own role in the situation. I dismissed his statement about Bay 4 almost immediately, filing it away as further evidence of confusion rather than considering it as potentially valid information. That assumption was wrong, and it nearly had serious consequences for another patient. The CMO, absorbing the full weight of the situation, turned toward broader institutional implications. "This isn't simply about one incident," she said. "This reveals a pattern in how we assess patients based on presentation and circumstance, a pattern that can cause us to miss genuinely valuable clinical information, whether from a patient's own self-report or, in this case, from a patient who happened to carry medical expertise that our assumptions prevented us from recognizing." Over the following weeks, the hospital implemented formal changes to how staff assessed and engaged with patients experiencing homelessness or apparent psychiatric crisis, specifically incorporating training on avoiding premature dismissal of patient statements based on presentation or circumstance. Kayla, deeply affected by her own role in the near miss, requested to remain involved in Whitcomb's ongoing care as his treatment shifted from the initial trauma assessment toward addressing both his physical health and his underlying substance dependency. "I don't know if I'll ever practice medicine again," Kayla told him during one of her visits weeks into his treatment. "That's a considerably longer road than getting sober alone. But I appreciate that this hospital finally saw me as more than just the circumstances I arrived in." "You should know," Kayla said, "that patient in Bay 4, the one whose complication you caught, he made a full recovery. His family specifically asked if there was a way to thank the person who identified the issue in time." Whitcomb was quiet for a long moment, something in his expression shifting with visible emotion. "That matters more than I think I can properly express. Being able to help someone, even now, even like this, that's not something I expected to feel again." Foss, in the aftermath of the incident, requested that hospital administration formally recognize the specific value of patient-provided clinical information, regardless of the patient's presenting circumstances. Implementing a policy requiring documented consideration of any specific clinical observation offered by a patient, rather than allowing such statements to be dismissed based purely on initial categorization. "I nearly let a serious complication progress considerably further because I'd already decided a patient's clinical observations didn't carry weight, based entirely on how he arrived rather than what he was actually telling us," Foss told the assembled ER staff during a training session. "That's a mistake I don't want repeated in this department." 2 months later, Fairhaven General looked much the same on the surface, but something underneath had shifted permanently. New protocols required staff to document specific consideration of any clinical information offered by patients, regardless of presenting circumstances. A structural change specifically designed to prevent the pattern that had nearly cost a life during Whitcomb's case. Kayla changed the way she approached patient assessment entirely, no longer allowing appearance or circumstance to shape how seriously she engaged with what a patient actually said. "Listen to the words, not just the context they arrive in," she told incoming staff now, a lesson learned directly from her own uncomfortable reckoning. Whitcomb, progressing steadily through both his addiction treatment and the broader process of rebuilding stability in his life, remained in periodic contact with Kayla and Foss over the following months, a connection that had begun in the most unlikely circumstances imaginable. "I don't know exactly where this path leads," he told Kayla during one of their later conversations, "but I know it looks considerably different than it did the day I arrived in your ER, mumbling about a differential nobody wanted to hear. I'm glad someone finally listened, even if it took a laminated card falling out of a pocket to make that happen." Sometimes that's exactly how these things go. The truth was there the entire time. It just took the right piece of evidence for anyone to finally take it seriously. Because everyone at Fairhaven General finally understood what a single worn medical license had proven beyond any argument about appearance or circumstance. Expertise doesn't disappear simply because life's circumstances have stripped away every visible marker of it. The most valuable information in a crisis is sometimes offered by exactly the person everyone else in the room has already decided isn't worth hearing. Dignity shouldn't require proof to be extended, though sometimes proof is exactly what finally forces people to offer it. And sometimes the man dismissed as confused, disheveled, and unworthy of serious attention turns out to be the only person in the entire building who actually sees what everyone else has missed. The end. This story is fictional and created for entertainment purposes only.